So let's start with the story. 2-year-old, and this is an injury film. I know it's not a very good picture, but what do you think you want to do here? How many would just give a plaster on OPD basis? Just raise your hands. Okay. How many we want to do full POP on OPD basis? Okay. Close reduction and plaster? Okay. And IM nailing? Nobody. Okay. This child was treated like this. Sorry for the film. This is how the plaster was removed, and he came to me with cubitus varus after 8 years. Any guess what is happening here? Cubitus varus in a forearm fracture. We are running late, so I will just show you that Ulna had gone for non-union. And do you know what the cause is here? Anybody? Any guess? Open reduction. As I told in the morning, majority of the non-unions are related to operative intervention in pediatric forearm fractures. So this is a paper which shows Ulna non-union, majority it was open, and here also this paper also says majority is the cause is the open reduction. So operative treatment is on increase because parents are demanding to us. We are not comfortable doing plaster treatment. We are not able to explain the parents once the angulations are there in post-operative X-ray, and people don't pay us well if we do not put any metallic implant in our practice. And this all as combination has led us to do more and more operative. So 9-year-old, isolated radius injury. What is your choice? Anybody ready to give plaster on OPD basis? No. Close reduction and POP? Isolated bone. Only one person. IM nailing? Okay. And plating because of single bone fracture? Okay. So this is what I tried doing close reduction, but this is the best I could got, and the moment I got it to length, it used to angulate. So ultimately I accepted this, and Ashok told, I had attended Ashok's lecture earlier, he said that things will remodel, and it did remodel, and this is the functional result. And it tells us to say that you do not need to open a forearm bayonet reduction if it is less than 1 centimeter overriding. Contrary to this, let's look at this 6-year-old male. This is the injury films, and this is how the child came to me on day 2. This is the angulation. What do you do? This child was asked, this doctor parent were asked to come go for re-reduction and plastering. They refused. Child came back after 6 weeks with union with a 30-degree angulation, and at 1.5 years they still had a persistent 20-degree angulation because the angulation criteria described by Rice Charles were not followed up. This child did not have much functional problem, but if you can look at his right side, the pronation is definitely restricted. But fortunately it is forgiven because God has given us enough amount of abduction to compensate for the pronation. So mid-shaft fracture, you cannot accept angulation beyond the limit which Dr. Ashok already mentioned. But if it's a translation, it looks really bad to the parents, but if you can convince them, you can continue with a conservative treatment, and ultimately they will bring you 2 more patients, and it will be financially also lucrative. So 8-year-old male, fall on outstretched hand. This is the post-operative picture. How many of you are ready to accept this? Yes. How many want to re-operate this case? Yes. Why, doctor? Why you want to re-operate this? Sorry? Proximal? But at this point of time it is aligned. How are you sure that it will in future it will happen like this? Okay. So this is the post-reduction film. If you look at the film carefully as taught by Dr. Ashok, you will see that the radial tuberosity is seen here, but the styloid is not seen there. So this is a 90-degree malrotation, and here you can see the radial styloid. You do not see the radial tuberosity in the same film. Right? So this has been already told. So I will not reiterate. So this is the post-reduction film of re-reduction film. Will you accept this or not? I have done it. Who dares to say I will not accept? Anyway, So now we have got the rotation right. Don't look at only the fracture side, look at both sides, and this is the functional function on the follow-up. What you need maximum rotation. If you get the rotation right, the rest of the things will be taken up by this. Most important problem which we cause is we take a very small X-ray. The elbow and wrist are together, and that is why we miss sometime rotational malalignment. 12-year male presented with this type of fracture. I think this is a indication where you can go ahead and do nailing, because more adolescent children, the outcome is like an adult. What you need to take care is take a posterolateral entry from Ulna, keep the distal end of radial nail proud above extensor retinaculum, respect the radius distal radial physis, maintain the radial bow, and maintain the interosseous spread. If you do this, you're going to get good results. You all do more nailing than I do. I don't need to teach you anything beyond this on this topic. This child, another most important thing, we all have started using 10 nails, and I have in my more than 70% of the fixation, I still use K-wire, which cost about 45-50 rupees, and it gives equally good result. There is not a single paper which tells me that 10 nail fixation with its pre-bending gives a superior result compared to IM K-wire. This is the functional result of the same child. Somehow he remembered to get the nail done after the COVID and everything was over, about after 5 years. So 3-year-old son of a pediatrician, whose uncle happens to be my postgraduate student. He had a fall like this. He put it in a plaster after looking at IITV, removed the plaster and never took a follow-up. Child had a fall again after few months, broke this. And this how was the deformity. How many of you would like to operate this child? Because now this is a refracture within 4 months of the first injury. How many would like to give plaster? Please raise your hand. Okay, and how many would like to refer to Preethi Hospital? Please raise your hand. Okay, there are a few hands, good. So, Dr. Shiva, I am doing my job well. So, this is the best position. Yes, will you discharge the patient? Or you would do something to the radius? Wedging, but this is under anesthesia only right now. See, this is IITV films. Couldn't get better. 1 week later, ulna also displaced. You see, I gave a plaster with board. You can see very straight ulnar border there. But even after that, swelling got down. So now what? Yes, Vidyasagar, you want to say something? K-wires. Okay, you have at least gone one scale down from 10, so you come down to K-wire. Okay, if you stay with me, I'll stop you operating. So what I did was, what Ashok told me, you can do that. I did a wedging here. Now we have got a reasonable alignment with radius and ulna. That's 5 months later. And this time I protected the child with a brace because this was a naughty child. There are papers saying that green stick fracture tends to refracture more than open complete fracture, and you should use brace. And this is the 2-year follow-up of the same child, this excellent remodeling. So when you get forearm fracture next time, well-modeled plaster is an art forgotten. We need to relearn that. And if you do not get it on first attempt, 1 week later, you still have a second chance where you can do wedging and correct and still continue with your conservative treatment. Nailing is a good option for older kids and in some special situations like OI or pathological fracture. But do it well, follow them up till complete union, document radiological union, especially if you have done an open reduction. And K-wires do work very well. TENS is not must. And be ready for occasional surprises I have shown you. Thank you very much for your kind attention.